We have Dr. Lilia Cervantes, who is at Denver Health, and you are the Associate Director of the Center for Population Health. Is that correct?
Yes.
So thank you very much.
Hi, everyone. My name is Lilia Cervantes, and I'm an internal medicine physician researcher. And I'm very excited to speak to you today on the topic of undocumented patients with kidney failure and access to care. I'm funded by the Doris Duke Charitable Foundation as well as the Harold Amos from the Robert Wood Johnson Foundation. I'm going to briefly talk about background, some of my research, future research directions, and then policy implications. First, my inspiration for research. I was a clinician for about 6 years full-time, and I transitioned to research about 3.5 years ago. And this was following a clinical experience with the woman you see pictured here. Hilda, the woman holding the baby, was an undocumented patient with kidney failure. And in Colorado, undocumented patients with kidney failure do not have access to care. So she came to our hospital once a week, critically ill, when she was near death. She had 2 boys when I met her, both elementary school aged, and goodness, by the time she died, she probably had about 3 or 4 cardiac arrests. The boys were not doing well. They were suffering significant physical and psychosocial distress because of this. They wouldn't leave her side because they were worried that leaving her side meant she could have a cardiac arrest and no one would be around to call an ambulance. And so it was after she passed away that I was inspired to transition to a full-time research career. Very briefly, for those of you that don't have a medical background, the kidneys, the function of the kidneys is to filter the blood and remove excess fluid and toxins. Life is not compatible without kidneys. In fact, people typically die within 1 to 2 weeks when kidneys fail. And the standard of care in our country for patients with kidney failure is renal replacement therapy, the most common form being hemodialysis. In hemodialysis, patients are on a dialysis machine for about 4 hours, 3 times a week. And the dialysis machine does the job of removing the excess fluid and removing the toxins from the blood. There are nearly 6,500 undocumented immigrants in the country with kidney failure, and their access to standard hemodialysis varies. In fact, the majority of states offer emergency-only hemodialysis. This is driven by payment. And so, as Dr. Schenker and other people alluded to this morning, undocumented immigrants are excluded from the diagnostically based 1972 Medicare end-stage renal disease program. They're excluded from traditional Medicaid programs, and they're also excluded from the provisions of the Affordable Care Act. Instead, care for this community is basically reimbursed by emergency Medicaid. And for those of you that may not be familiar with this federal language, the Emergency Medical Treatment and Labor Act states that Medicaid payments shall be made if such care and services are necessary for the treatment of an emergency medical condition of the alien. This means that to access care in Colorado, these patients have to be seen through the emergency department. At my hospital, there are about 70 patients that are undocumented with kidney failure. They come in once a week through the ED. They have a set of vital signs, labs, an electrocardiogram, and we look at these criteria and look and see if they meet criteria for being critically ill, for emergency-only hemodialysis. And so sometimes these patients will come in, they'll look visibly ill, but if they don't meet these criteria, we'll actually turn them away. And maybe they'll come back the next day, but they're critically ill. As you can imagine, this kind of care is extremely expensive. In fact, a study in 2008 showed that it was 4-fold more expensive because of the ED visits, the weekly ED visits, and because they're sicker, they tend to end up admitted to our hospital and in the intensive care unit. They also have more complications and need blood transfusions. And as you can imagine, this kind of care is physically debilitating, so these patients have a lot of symptoms. And so after my patient passed away, I initially did some advocacy, and started reading up on every possible perspective piece that was ever written on this issue and a couple of studies that had been done. And I came across one that further inspired me to transition from clinical to research. This paper was written by Dr. Straub, who at the time was the chief medical officer for CMS. And in here, he says we need more data, more evidence-based comparative analyses and cost-effectiveness analyses on the best way to treat this population. I, just as an aside, was born at Denver Health. This is the safety net hospital here in Denver. My parents moved here about a week before I was born so that I could have citizenship. And so this story, my patient's story, really sort of made me realize that rather than doing, advocacy work, what I could do is use my medical degree to pursue research and begin to build the evidence to change policy. And so some of my initial research questions were, number one, this patient population needs to have a voice. They're extremely vulnerable, and as Dr. Schenker said, they're very hard to research. And so I wanted to give them that voice. What are their perspectives on this kind of care? And then I also wanted to give the clinicians a voice because we are compelled to provide this type of care. How does this kind of care impact us? And how does this impact mortality? And so this first paper, as I mentioned, the objective was to understand patient experiences. And I used semi-structured qualitative interviews and interviewed about 20 patients. I sat down with them for about an hour and just talked to them about their care. And I ended up publishing this in JAMA Internal Medicine, which was incredible because it received a lot of media. And so finally we were able to sort of highlight this issue from the perspectives of patients. So again, the patient voice. And I'm going to just very briefly touch on some of these themes in the interest of time. But the first theme was distressing symptom burden and unpredictable access to emergency-only hemodialysis. So as I mentioned, patients with kidney failure, the standard of care is 3 times per week dialysis. So they can drink a sip of water and know they're going to be dialyzed the next day and have all that fluid removed. For an undocumented patient, they're waiting 6 to 7 days. So every time they take a sip of water, a bite of watermelon, a spoonful of soup, all that water stays in their body until they can access dialysis when they're critically ill. This means that this water can sometimes third space or move into the lung cavities or into the legs. And so when I talked to these patients, a lot of them talked about the sensation of feeling like they were drowning. One patient said, sometimes I come in almost drowning. Last week I was discharged on Friday and Tuesday. I came back and was doing badly. I couldn't breathe well. I had to go to the intensive care unit. Another patient said, I don't want anyone to resuscitate me if my heart or lungs stop. It's not that I don't want to live, but sometimes the symptoms make one feel that one would be better off dead than alive. The second theme was death anxiety. So as I mentioned, the patient that inspired this research, by the time she passed away, she had had 3 or 4 cardiac arrests. This is common for patients because they come in with such a high level of potassium that it affects their heart rhythm and their heart stop, basically. So one patient said, I've had people pushing on me right here, my chest. I think it's happened 3 or 4 times, but I don't remember much except that my chest hurt a lot afterwards and my family thought I was dead. Family and social consequences of accommodating emergency-only hemodialysis was the third theme. As many of you know, for Latinos, family is number one, sometimes coming even before the patient themselves. And so when patients talked about what was most distressing, they always talked about their families because it was very distressing for them to see their families so sad about how they looked and how they felt. And, just as an aside as well, 2 of the 20 patients that I spoke to had children that had tried to commit suicide as a result of having to, deal with weekly near death, is my parent coming back next week? So one patient says, my daughter is sad. Sometimes she is shocked. She's more worried than me because she used to wear makeup and now she doesn't. She's so sad. Our fourth and final theme was perceptions of healthcare system, gratitude for emergency-only hemodialysis, and healthcare professionals are highly valued. These patients, as I mentioned, are at our hospital once a week. So we get to know them very intimately, not just them, but also their families. And we care about them, and we get invited to family events. And so a lot of these patients expressed deep gratitude towards the caring and personalized approach that they felt from their clinicians. So one patient says, a lot of compassion. These people are truly kind. I have never come across anyone that has made me feel negatively. So in conclusion, patients suffer tremendous physical and psychosocial distress. This next study, as I mentioned, looked at physician or clinician experience with this type of care. And I used the similar design, so semi-structured qualitative interviews, but this time we interviewed 50 clinicians, 25 in Colorado and 25 in Houston, Texas. And this study is in press with Annals of Internal Medicine. And I'm just gonna very briefly again go through these themes and describe some of the quotes. So theme one was professional burnout. Clinicians described navigating very conflicting emergency-only hemodialysis criteria, feeling like they needed to overextend their duties to bridge care, feeling like they were jeopardizing patient trust by providing this type of care, and internally suffering because of all the mortality and symptom burden they were observing. And so one clinician said, I pray every morning before coming here that nothing bad will happen to my undocumented kidney failure patient. The second theme was propagating injustice. Clinicians described feeling like they were providing standards based on perceived worth, and that there was too much of a focus on volume rather than quality, and there was a sense of gaming the system. So many of these patients, as I mentioned, if they don't meet the threshold for critically ill criteria, they may be turned away from the emergency department, from receiving the emergency-only hemodialysis. And so sometimes what clinicians observed were these patients walking out of the hospital because they didn't meet criteria, consuming a food high in potassium, which, increases their risk of death, and then coming back to the hospital, sometimes having a code or needing CPR in the ED because they consume so much potassium. One clinician says, it's kind of like they're treated like dogs in a lot of ways. It's really very heartbreaking. The third theme was perverse payment model and use of limited resources, wasted hospital resources, and confusing financial incentive. And so there's a lot of confusion as to what drives this type of care. Is it reimbursement? Are we making more? Are we losing money? And concerns about the unsustainability of this model, because the numbers have doubled in the last 7 years. One physician says, so you're asking me to keep a patient sicker so you can make more money? I'm sorry, but that's not why I became a physician. Theme 4 was inspired to provide care, a strong sense of altruism and deriving inspiration from patients. Similar to what we saw in patients, the clinicians really deeply care about these patients because, as I mentioned, we see them once a week, so we get to know them really well. One clinician said, the emergency hemodialysis patients have made me a better doctor in the long term because we get some continuity with them. It has been nice. In conclusion, we found that physicians, clinicians, nurses, everybody suffer professional burnout when they are compelled to provide emergency-only hemodialysis. This third study was a retrospective cohort study looking at differences in mortality. So we basically compared undocumented immigrants that receive standard of care to undocumented immigrants that receive emergency-only hemodialysis. And here we looked at incident ESKD patients in San Francisco, Houston, and in Colorado. Our main outcome was mortality. We looked at 211 patients, and 40 of those were standard and 169 were emergency-only hemodialysis. The mean 5-year hazard of mortality for patients was 14-fold worse. And so you can see our cumulative mortality curve here on your left. The upper curve is the emergency-only hemodialysis patients, and the lower one is the standard hemodialysis patients. We also found, of course, that emergency-only hemodialysis spend tenfold more time in the inpatient setting and substantially less time in the outpatient setting. The last study I wanted to very briefly describe looked at the circumstances of death. So in these same patients that we observed pass away in that previous mortality study, we looked at some of the patient characteristics of patients that died in the hospital. There were a total of 35 patients, and what we found is that for patients that had a hospital death, their mean level of potassium on admission was 6.4. 15 had an admission diagnosis of hyperkalemia, that was the majority, and the majority also had an electrocardiogram rhythm disturbance, and the average number of days since the last session of hemodialysis for those patients that died in our hospital was 6 plus or minus 4 days. And so, in summary, in these past 3 years since my patient passed away and I started doing research, I found that patients suffer significant physical and psychosocial distress. Clinicians suffer professional burnout from providing this type of care. Mortality is 14-fold higher, and acute care days are more, and patients spend less time in the outpatient setting. And the circumstances of death showed us that these patients do have a very high potassium when they die in our hospital. So the implications, and I wanted to spend just a minute here. Dr. Salmon and Dr. Schenker alluded to the so what. What do you do with your research, and how does this translate into policy in the real world? My take is that we need some kind of national treatment strategy for these patients, because at the moment, care varies too much. Even within states, care varies between cities. Right now, we have completed one study, which was a peer navigator intervention. It was a pilot feasibility peer navigator intervention that provided patients with support for resources and emotional support. And the second study that we are almost completed with is a peer sort of group support group in our hospital where patients meet because they're hospitalized. So we meet with the patients once a month as a group. So in the meantime, we're trying to provide patients with this kind of support because of their suffering. But in the long term, really what needs to change is access to care. And so my hope is that over the next year, I begin to work with communities, with media, with legislators to try to change access to care, not just in Colorado, but nationally. Future research projects, we're going to look at caregiver burden and assess how this impacts the families of these patients, because as many of you know, a lot of these undocumented patients have documented children that are impacted by this type of care. I forgot to mention the picture here is a nicho, or death altar, that we put together for my dear patient when we celebrated Day of the Dead in 2016. And this is a picture of her sons. So the sons are in the front. And one thing I forgot to mention is that because she was suffering so much, decided she was going to withdraw care. She didn't want her kids to suffer. And so we gathered a multidisciplinary team and identified an incredible family that went through the foster to adopt process over 6 months. Hilda lived with them during this. And after they were adopted, we worked with the Mexican consulate to get her a visa so she could see her family one last time. But we've maintained connection with the children and their parents. In fact, I just had dinner with them last week, but these are the boys. Her oldest son is doing really well in school, which I'm really excited about, and he wants to be a physician. But this was a celebration of Hilda's life, of Day of the Dead. And my mentors, my funding, thank you.